Good evening, friends. Welcome to the Tuesday Critical Care and the Emergency Department related updates and meeting. We bring the debates, the topics which are curious for the medical fraternity. And this time we have another interesting topic that is an influenza overlap. For the last 2.5 years, we have been seeing there is a um, surge in this COVID pandemic and unprecedented overall the health strain. But in the simultaneously, we have seen the influenza case numbers were extremely low and been very small number of cases detected here and there. And there were many studies, including Dr. Hari, who is our extreme expert panelist today, had a paper where he's also so there is no much co-infections during the last 2 years in the previous published study by him. But recently, in the last couple of weeks, we have seen a series of cases which has H1N1 influenza positive with a typical viral ARDS where the RT-PCR and COVID were negative. So this triggered a kind of a discussion among our team members, including Dr. Hari, that should we bring this case series to the common medical community, which is facing now a surge in BA5 variant, where we are seeing a lot of case positivity across the country and across the globe in different parts of the world, where there are a lot of positive cases with which is a spectrum of more of a mild influenza-like or a flu-like symptoms, and they are turning to be COVID positive, and very few admissions also, the IP admissions after a long time of 6 months, where we are seeing influenza-related positivity. This time there is a change. They are not admitted with comorbidities, but they are admitted with typical lower respiratory tract or upper respiratory tract infection. We have seen 3 or 4 cases where the parenchyma got involved with typical GGOs, and very few cases, 1 or 2, where there is a ARDS also requiring an invasive ventilation in one of our unit. So with this, I think what we try to bring is Dr. Sujata, who is our DNB resident, will try to give an overview over what happened in the last 2.5 years, how these two viral influenza and COVID played a role in our ICU, and recently in the last 6 months, when this lockdown has been withdrawn in many countries, including us, and when the masks has been taken out from the mass gatherings, how influenza is also playing a role. To give the expert opinion on most of these aspects, we have our seasoned clinician, Dr. Harikrishan, who has been a leading interventional pulmonologist in this part of the world. And we are proud to have him on the panel today. Sir, it is a privilege for us to have you here, Dr. Harikrishan, sir. Thank you for being us. So once Dr. Sujata takes that overview, we will take the interactive session with you, Dr. Hari. So over to you, Dr. Sujata.
Yes, sir. Good evening, all. So I would like to present a few cases which we have seen in the last 2 weeks in our ICU. So before that, I'll give a small introduction regarding the H1N1 influenza viruses and the COVID, the similarities and dissimilarities between and diagnostic challenges which we have faced in our ICU with these cases. So influenza viruses, they are responsible for the seasonal outbreaks, and both the COVID and influenza are going to share the same symptoms, flu-like symptoms, but healthcare systems are now facing, there is an overlap of these two cases, like there are COVID cases, and along with this, we have an influenza outbreak in the last 1 month. There is an increase in cases in the ICUs, which we thought to be a COVID are turning out to be a H1N1 positive. So regarding the influenza, it causes a seasonal outbreaks. The symptoms of influenza, they are like mostly mild infections. They may present as a simple upper respiratory tract symptoms, and also when it comes to a severe form, it can present with systemic symptoms affecting all the organs. Mostly they are mild, and when it turns up its symptoms, the mortality is also high. Influenza infections, they are complicated with bacterial pneumonias too, causing high mortality. Along with the respiratory systems, these influenza viruses can also involve the other organ systems. So influenza is most common in children less than 2 years of age, and the other complications like neurological complications are more in the pediatric groups. When it comes to last 2 years, we have been with the COVID, and it is still persisting, but the last few months you can see the decrease in COVID cases. But this is due to we have a lot of vaccinations has been tried, and their high mutation rate, the high mutation rates for the newer variants. We have seen the newer variants in the COVID, which is causing a public health problem. So there were lockdowns, restrictions, and we have been using a lot of protection practices. And as there is a number of drop in the COVID cases, all these lockdowns, restrictions has been lifted, and now we can see influenza outbreaks. And these influenza outbreaks are being overlapped with our COVID-19, and this is causing a diagnostic challenge to a healthcare systems right now. So compared to influenza virus, there is a transmissibility of COVID is much more higher, and timely we have to detect this virus as soon as possible, because both are in severe forms leading to ARDCs with high mortality. So I would like to present some of the similarities and how their clinical presentations and some dissimilarities, how we're going to chase a case with our diagnostic equipments. Like influenza, the almost in the mild cases, the presentation of both influenza and COVID will be same. In influenza, we can have symptoms with fever, myalgias, dry cough, headache, ocular involvement, and respiratory complications as such. So they present as a viral pneumonias, and in influenza there may be a secondary bacterial pneumonias complicating the case, and they may exacerbate the chronic lung diseases. And the other organ systems which have been affected by this influenza viruses are musculoskeletal systems. They causes myositis, rhabdomyolysis, neurological complications, Rice syndrome, which is more commonly we see in the pediatric age groups, and also the cardiovascular system has been involved. When coming to the COVID, the symptoms, the other symptoms like fever, all these are same as of influenza. Like they present with the fever, cough, myalgias. And one more difference is this COVID patients may present around 30% may present with the GI symptoms like diarrhea, vomiting, nausea. And they present with the respiratory complications. Most of the patients will, majority compared to the influenza cases, COVID cases go into ARDS. And again, it's associated with the bacterial and fungal co-infections. And it also affects the neurological system, cardiovascular system, and we can see the renal complications during the COVID infections. And this is a flow chart which is going to give our differences between the influenza virus and the SARS-CoV virus. And the transmission of both the viruses through the droplet infections. And influenza viruses are less contagious than the SARS-CoV. And overall incubation period, it's very less, around 4 days in influenza, and around 2 to 2 weeks in SARS-CoV. And almost the risk factors are same in both the age groups. Like in influenza virus is more common in the extreme age groups, children like less than 2 years and more than 65 years. Whereas coming to the COVID, it is more we have seen in the advanced age groups with a lot of comorbidities. And the other common clinical features which I have explained before. Next, this is a data which has been given. This is I just want to show in this slide. the incidence of influenza during the COVID time. You can see the red mark is the COVID positivity rate, and the black is the influenza. As till COVID is there, there is a very minimal positive cases of influenza viruses. As there is a decrease in COVID cases, we can see a surge of influenza cases. This is the WHO data. This has given the spikes of influenza in India. This is the Indian data, where you can see the increase in influenza cases after the stoppage of, after the decrease in COVID cases. And this is about the COVID cases which have been which affected around 40 million people with the case fatality rate of 5 lakhs. This I would just want to tell you about the transmission ratio. This is RO number, reproduction number. It says about the how many persons can be infected by an infected person, like transmission rate. In influenza, it is around 1.3, but in COVID, it is still higher. It's almost double to 2.5. The incubation period, which I have already explained, it is more in the COVID, and the hospitalization rate and the case fatality rate is much more higher than our influenza virus in the COVID. So this is again our symptoms. This has been a meta-analysis which has compared the COVID virus along with the influenza A and influenza B. These are the common symptoms which are pictorial representation of each and every virus which is having a particular symptoms. Next, this is a graph which you can see from the 2000. We got a COVID pandemic, you can say, like from Jan 2020 to 2021. Before that, there is an increase of flu cases. But once there is a pandemic, we can see a drastic decrease in the flu cases. This is due to the, maybe due to the good practices, like we have been taking a good protections with the face masks and all. So along with the clinical symptoms, there are some radiological features which going to differentiate, which helps us to differentiate the H1N1 from the COVID. I'll share a few pics of COVID patients and H1N1 CTs. So in the COVID, we have seen GGOs like grounded glass ground PET CTs, which are more common in the COVID and also seen in 90% of H1N1 patients. Okay, this is a CT finding. We can see this is a CTs of H1N1 patient. You can see a mixed parenchymal or alveolar plus airway abnormalities which are seen in H1N1 patients. So the first in the first slide, you can see a tree in blood appearances and some ground glass opacities. And the second one, we can see the bronchiectatic changes. This is H1N1 CT. Next is this is a CT of a COVID patient. Here you can see GGOs in A, and you can see in a B slide, we can see a crazy paving pattern. Next, one more important thing is about CT. When the influenza or COVID, it is in mild stage, then only you can differentiate in the CTs. When it comes to the severe influenza or COVID state, it goes to the full-blown ARDS, and CT may not be so helpful to differentiate influenza and also COVID. This is again a CT which is been showing upper two peaks, A and B are of COVID patients, showing bilateral upper and lower lobe ground glass opacities. And you can also see the crazy paving pattern in the B slide of the upper one. And C and D are H1N1 patients, CTs. So this is a full-blown picture where the both patients had influenza. The upper slide is about COVID and the downwards H1N1, where you can see almost the CT findings are same. In the severe stages, it goes to ARDS, where you cannot be differentiated by your CT alone. So I would like to present a few cases. My first case is 28-year male patient who presented with sore throat, fever, myalgia, cold, shortness of breath. Is a recent case. He's been admitted in outside hospital. There is a history of travel. He returned from Dubai a week ago, and he got admitted in an outside hospital. His HRCT was done. It was showing a CT severity of 2/25, and he has been received 3 doses of remdesivir, solimedrol, and all, because his COVID first report seems to be positive outside in outside hospital. Next, due to the increased oxygen demand, they repeated the other CT, which was showing increase in severity. And he got shifted to our hospital, and on receiving this patient in ER, we could find this vitals. He's been running fever, and the vitals hemodynamically he was stable, and SpO2, like it is around 90% on 10 liters of oxygen. So regarding the past history of this patient, he got COVID in the first wave, and he's been admitted to the hospital for 10 days. He received a minimum oxygen support and got discharged. He has received 2 doses of Covishield. And okay. Next, I would like to share the CT of this patient. This is done in a hospital on the day 1. Okay. This is the CT which we have taken. The first day, the patient is on NRBM mask with 15 liters of oxygen. He is maintaining around 90 to 95% of saturations. And on the day 2, the patient's oxygen requirement has increased, and he's been little tachypneic. So we have kept the patient on HFNC with a flows of around 60 liters, and FiO2 is around 90, and his saturations we could maintain around 90 to 92%, and we could maintain the patient on HFNC. And we have sent the pneumonia panel sputum cultures, and the pneumonia panels turned out to be influenza A positive. We have started on capsule oseltamivir 75 mg BD, and we have done the RT-PCR, which is negative in a hospital. And day 3, he's just continued on HFNC. We could maintain slowly. The patient has been the oxygen support which we were giving, it started with the 90%, and slowly we could bring down the patient to 80%. And the day 4 and day 5, he's on HFNC. Almost around day 7, we could bring down the patient on NRBM mask. So on day 7, the patient has been given an intermittent HFNC and NRBM, and around day 8 and day 9, he is completely on NRBM mask. And right now the patient is having only just 2 to 3 liters of oxygen with a nasal bronch, and his respiratory rate, everything, respiratory, everything got down, and we successfully we shifted the patient to step down. So there's a other case. Case 2, it is a 58-year-old female patient. She presented with fever, chills, myalgia, throat pain, headache since 5 days. She also have a history of Haridwar for 1 week back, and she's a known diabetic hypertensive. She is also post-COVID status, and she got a COVID in 2021. On presentation, her saturations were only 83 in her ER on room 8. And so we have given her 15 liters of oxygen. She could maintain and 92%. She is running a continuous fever. The maximum temperature is 103 degrees Fahrenheit. So we have done a CT in the ER. It was giving a CT severity of 10/25 with diffuse multifocal patchy consolidations and GTOs. We have sent the RT-PCR, which is turned to be negative. So we have started on fluvir, piperacillin, sulbactam, and clarithromycin the first day. On the second day, her oxygen requirements has been increasing. She couldn't maintain on NRBMS, so we started on HFNC. We started with FiO2 of 70% with flow of 50 liters, and we could manage to, she's maintaining a saturations of 92. She's running a continuous fever spikes, and we have escalated our antibiotics. On the day 3, she has a worsening respiratory distress. So we have started, we have intubated the patient, invasive lines of praise and bronchoscopy was done. We have sent the bowel sample for the pneumonia panel, which turned to be influenza A positive, and her COVID RT-PCR is negative. So immediately after intubation, her PF ratios were very low, less than 150. So we gave a first session of proning. Immediately, I mean, after 2 hours of intubation, her PF ratios after intubations are 125. So these are the ABGs. Okay. On the day 4, on day 3, we have intubated, and we have given almost 20 hours of proning session to her, and we could see there is an increase in PF ratios were more than 200. We have supined the patient, and we could bring down the FiO2 from around 900% to 40%, and the PEEP of 10, and her saturations are around 96%. So her cultures, we have sent all the cultures which are turned to be sterile. There was a slow improvement after from the day 5. We have given only one prone session. She has responded so well. After that, throughout the days, her PF ratios are more than 300. So there was a improvement in her chest rate. There was a resolving pattern, and we started giving a spontaneous breathing trial. On the day 6, we could extubate the patient on NIV, FiO2 of 14 and minimum supports. And after this, the patient is being shifted to nasal prongs. One day we have given NIV, and then the patient improved drastically, and we could shift the patient out on the day 8 out of ICU. This is a CT of this patient. Okay. The other case is third case, 51-year male patient. She was brought to the ER. This patient has been got treated in the outside hospital. He had symptoms for 5 days, presented with fever, cough, shortness of breath. There was a respiratory distress, so he got intubated in the outside hospital. We received the patient on ventilator to our ER. So we have repeated the HRCT, which is showing multifocal patchy parenchymal opacities with ground glass opacities, and bilateral lungs are involved with atelectasis in the basal segments of bilateral lower lobes. We have sent the respiratory filmary, which was showing influenza A positive, and RT-PCR is negative. Started on antibiotics, antivirals, and other supported treatment. This is a CT of this patient. So we have sent all the cultures. The bronchial culture, blood culture, urine cultures are all negative for this patient. And this patient almost, he is on ventilator for over a week. There was a slow improvement in this patient over a few days of over 1 week. After 1 week, we have given a spontaneous breathing trial, and we extubate the patient on NIV. So he was there on NIV for a day, and later we could bring down the oxygen support, and gradually, and patient got discharged within 10 days of admission. Yes.
Thank you, Dr. Sujata, in bringing those cases. The reason behind this seminar is we realized in the last couple of weeks, there is a definite surge of both COVID cases, and parallelly, we have seen some respiratory other cases which turned to be influenza positive. And that made us an eye opener, like let us bring this case series to the medical community so that this will be kind of a way forward, as we are seeing a monsoon season, a lot of rains. So we may have a surge in the cases. And we have seen like almost 415 million COVID positive cases and almost 6 million deaths. And from fortunately for the last 6-8 months, we have not seen a very sick COVID case which needed a invasive ventilation with the same bad ARDS requiring proning or ECMO in the last 6-7 months after the last 2021 November, December. Those were the last part. In Omicron variant also, we have seen many cases which had a lot of comorbidities, came to a hospital, found to have coincidentally positive with the COVID-19 RT-PCR on RAD, but there were no typical COVID-related ARDS which we have seen. But there is a change in the recent time where we have seen less of COVID-related ARDS, but in maybe in the 20 admissions or 25 admission right now we have in IP with high-grade fevers, very bad LRTIs. Most of them don't have a COVID-related typical parenchymal involvement, which we have seen in the early two waves. So Dr. Hari was actually witnessing these cases. The case which Dr. Sujata was talking about, a young guy who was from a very connected, well-influenced, well-connected families of the middle part of the India, was airlifted to Dr. Hari in the better care because they were scared of those CT findings which we have seen. And Dr. Hari, to be very honest to you, the initial CT was very prompting to me, even though there was a RT-PCR rat negative. Can I still be considering this as a COVID case?
Thank you, Dr. Kola, for inviting me on this panel. This is very important at this time. Why? Because you have dengue fevers going on, and then end of COVID pandemic, and also right now we are seeing some of the cases in the ICU being influenza, being diagnosed as influenza. So why this case is important here is like I'll tell you this clinical history. His initial COVID RT-PCR was positive from a very good lab from outside. So his initial CT started as a small parenchymal GGO on the left side, and then in 4 to 5 days time, his oxygenation dropped and his basal consolidations progressed. That's the reason why he was airlifted to Yashoda Hospitals. So initially, I also had a doubt whether this is a COVID because he's already been treated with steroids for 3 to 4 days, and we continued to give 1 2 days of steroids until our reports came positive for influenza. So this kind of overlap situations are why it is important also is because in COVID we have seen a good response to steroids in these kind of mostly it's a pneumonitis like picture where inflammation is very well responding to steroids. But in influenza, if you we never thought of giving steroids to these patients. So then we cross-checked his previous vaccination status. He was traveling to Dubai. He was vaccinated thrice for COVID, and also his IgM was negative and IgG was around 1,000. Then we got a doubt why with an young guy with no comorbid illness, why he's deteriorating rapidly. And then we cross-checked with the new biofire film array, and also twice the samples, also including the lower respiratory tract sample on sputum, also turned out to be SARS-CoV-2 negative and influenza A positive. Then we changed our diagnosis as influenza pneumonia, and then he responded well after treatment. So this is, I think a few of our ICU cases are there with these kind of presentations, and this becomes more important when you're making a decision on administering corticosteroids or not due to these kind of pneumonia patients. Yes, definitely, as you said, looking at the CT scan picture, um, if there was no COVID, we can consider it as influenza because the season is more towards influenza. But I think there is no. I don't say it's a mistake or some. If we think this patient has COVID based on radiology, because there is a lot of overlap between influenza and COVID on the radiology also.
So Dr. Sujat actually pointed out initially that the early part, when you talk about a milder segments of these cases where we see subtle GGOs here and there in the peripheries, you can make out very clearly a difference between the SARS-CoV-19 versus influenza. But when it comes to an extensive involvement with the whole of the segments, all the segments of the lung involved, when you say diffuse alveolar damage, ARDS kind of picture, there is a challenge in differentiating. What is your take on that? Do the CT scan relied or CT scan based clinical judgment still holds good, or do we need to be more careful now?
I don't say clinical judgment is definitely, because before COVID, influenza has a positive clinical judgment of around 80%. That means in a season like where there is an influenza going on, your clinical symptoms will make you diagnose influenza based on symptoms in 80% of the cases. And most often we don't do influenza testing except if you're doing in a epidemiological things or as per hospital policies. So radiology, if you ask me differences between COVID and influenza, usually COVID is like a bilateral disease. You don't see a lot of consolidations in the initial phase. And also, if you talk on COVID radiology, depends on what phenotype of COVID the patient is having. If the patient is having a thromboembolic type of phenotype, we have seen more of subpleural GGOs with microthrombi and diffuse involvement from apex to base. But when it comes to influenza, usually it can be sometimes more unilateral. Again, organizing pneumonia kind of pattern on radiology was seen more in COVID pneumonias compared to influenza pneumonia. So we have not seen much of patients presenting as OP when it comes to influenza. And the distribution of radiological infiltrates may be central in some cases of influenza, but it is more periphery in when if the patient is diagnosed with COVID. So these are the basic radiological differences, though there is an overlap, but still some features can help you differentiate between COVID and influenza, which is not means you cannot make a clinical judgment based on radiology because both are coexisting together at this time, like in our patient.
Yeah, so the other component is from 2020 onwards, in 2021, what we have seen is because of the ongoing pandemic, there was a lot of restrictions of gatherings, there is a lot of restrictions in travel. So there is mandates of masks, and there was lockdown. So we have seen not many cases of influenza during this period. And as we see after the third wave of Omicron in the early parts of this year or the last part of the last year, in the 6 7 months, there is a lot of travels opened up, gatherings opened up, and the masks were dropped down. And do you think that's the reason why now there is a possibility that in this monsoon season or this winter season, there is a likely possibility that we may see a surge in all the other viral respiratory illness like what we used to see pre-COVID era?
The current reported, like as per the latest report, current instance is around 72 per 1 lakh population with this current influenza, which is less than 2020 and 2021. But because we also have done one, like we randomly checked patients. One study came from the UK initially during the first wave of COVID, that there is around 7% or means co-infection with H1N1 or influenza other viruses. But as per the current reports, like it is still lesser than the pre-COVID era. But we don't know because the predominant strain they are saying is like H3N3, but we still are seeing H1N1 more commonly here, more of influenza A H1 strain we have seen. So we may have to wait for some more time and then do testing in all these patients who present with radiological infiltrates that are consistent with both COVID as well as influenza.
So for the milder cases, so what I see in the community level at this point of time, there are many school-going children, there are many elderly age group patients, many families are complaining about the typical flu-like symptoms, fever, running nose, coryza, cough. So do you think there is any difference right now? Either it is an influenza or COVID, because I think we are not testing many at home. Most of them are getting symptomatically better in a very quick time, maybe a day or two. And most of them had more of upper respiratory tract symptoms. So at a community level, what is your message? Do we make any difference whether it is an influenza or a COVID, or it is like a common cold, which you behave like what you used to do before COVID?
Again, it is very difficult to differentiate both because most of the symptoms overlap. But if you look at differentiating symptoms between influenza and COVID, influenza again varies what age group the presentation is. Like if it is a neonates or small kids, usually they present with fever, febrile seizures, and also GA symptoms are more common than adult population when it comes to influenza, and they present with myalgias and all. But in influenza, usually with the adult population, it is like a fever with more of fatigue and confusion like state. These are the common presentations. And some differences, what we also noticed is like more of lymphopenia is seen in SARS-CoV-2 infections compared to influenza. And GA symptoms reported instances ranged from 30 to 40% in COVID, which is not much common in influenza viruses. And also we have seen in the lab parameters, there is a drop in platelet count and also prolonged coagulation profiles, more in SARS-CoV-2 infections than in influenza infections. I think these are the most common differentiating factors between influenza and COVID. But again, when you talk on this, like practicality, how far without a test, we cannot judge what infection this is, and we don't make treatment decisions based on these lab parameters. But these are the changes what we have observed. And also in COVID, we have seen a little elevation of liver enzymes also compared to previous influenza infections.
Dr. Hari, these are the findings when you talk about signs and symptoms in admitted, hospitalized, evaluated cases. In a community layer, when we talk about a very subtle community spread or a community wave of this flu-like symptoms, what is your take? Now, there are many calls because of this last 2 years of COVID pandemic. I have fever, I have cold. What do? I got COVID. It was too bad at second wave. So do I react and do I test? What is your advice? Do we test them? Do you advise them to be careful like what we see in COVID, because still we have COVID cases coming positive? What is your take at community?
I think more of influenza testing is more important than COVID testing because most of the patients are already vaccinated or previously infected with COVID. So I think it is important to test for more of other viruses than COVID at this point of time. Even though they are getting tested positive for COVID, we see our ICUs are not full with sick patients with COVID-19. Most of our ICU patients are with influenza. So I think it becomes more important to, because starting very early treatment in influenza makes a difference in patients, in a subset of patients.
So you're making a point saying that right now we had a mixed kind of immunity, both with vaccines and also had a natural infections spread across all the age groups in the second wave, third wave altogether. So that is giving some kind of protection right now to the COVID. Whereas because we had not seen many cases of influenza in the last couple of years, and now we are seeing there is a surge in cases, we need to be careful when it comes to the hospitalized patient, at least when it comes to the hospitalized patient who are sick, not just looked at COVID, but also look at influenza. So that's what you are trying to take a message.
Yes.
And there is another component when you actually spoke about this vaccines, Dr. Hari. So we have seen the vaccination happening at very high motivation for all the COVID during the last 1 year, 1.5 year in all the countries. What is your take? See, remember is many of our healthcare workers, many of our kids got the influenza shot in 2019 as a last, and after that, influenza vaccine was not available. So, what is your take? workers, or you take about a school going age group, or that too in any other immunocompromised or a high risk patient. So my concern in your context, because you say the COVID immunization is covered well, there is also a natural immunity because of the infection which has actually happened to all. So now influenza vaccine plays a role.
Yes, definitely. We have to vaccinate all people, like from starting from 6 months of age and above, with influenza vaccination, standard vaccination, and for especially for children who are not vaccinated before, like if they have not taken any influenza vaccine before, and they have to take a second shot of influenza vaccine after at least after 4 weeks of first dosing.
No, I'm talking about influenza. Every annual year we used to take because of the shift and drift, which we all know was a common phenomenon. And year we used to get a new kind of mutant variant, and we used to get a vaccine. So I'm talking about the school-going childrens. And now also there are a lot of questions related to the pregnant women who are coming with some kind of influenza, where we have seen influenza pregnancy was a very high risk group, contrary to what we have seen in COVID. Obesity was a high risk group in COVID, but not what we have seen in influenza. So there was a subtle differences in them, and high risk group in influenza was always pregnancy. So do you actually recommend for a pregnancy and pediatric age group vaccination now?
Yes, 100%, because the safety and efficacy of influenza vaccination is very well established in pregnancy, and since, as you said, they are more high risk and prone for more severe symptoms. It is important for, because most of the patients coming to OPDs also have these questions, like I'm pregnant and do I have to take vaccines? It is very important to educate them that these vaccines are very safe, and we have to recommend all pregnant women to take influenza vaccine with the current ongoing cases. And the if you talk on efficacy of vaccination, mostly in pregnant females, usually the second and third trimesters have shown to be more beneficial. But however, there is no adverse fetal or maternal events that are documented with previous influenza vaccination. So it is safe for both pregnant females and also for children to take vaccination.
We will take some questions from audience, Dr. Hari, and there are some viewers who are talking about spacing. Can I take both vaccines, influenza, COVID together in the schedule, or do I need to have some spacing between influenza vaccine and COVID vaccine?
No, there is a new recommendation that both COVID and influenza vaccine can be taken on the same day, and also pneumococcal vaccine and influenza vaccine can be administered concomitantly. So these are the recommendations. So there is no need to wait to take influenza vaccination after your third days of COVID vaccination.
So both the vaccines can be taken simultaneously in the same day as a schedule. Yeah. So there is another question that can I take an influenza vaccine now during this epidemic where we are seeing a surge already?
Yes, we have to take a vaccine. If you're not vaccinated, it is important because just now I think we have seen a small spike. So the current vaccines, like we have Fluarix Tetra now, the current strain vaccine. So it is important to take these vaccines, all of us, especially healthcare workers also.
So there is another question, interesting question, which we all ask ourselves: why steroids were recommended in COVID and was also helping them in our all the platform trials which we have seen during this COVID, and why they have shown worse outcome in influenza. In that case, steroid exposed patient diagnosed later as an influenza. What do we do? That means probably he's talking about initially we thought it's a COVID and we initiated like what happened in our case. Later on, it turned to be an influenza, or there is a co-infection. What do we do?
Steroids and COVID, if you say COVID, mostly it behaved like pneumonitis. Like if you see a radiation induced pneumonitis, which is very steroid sensitive, the same way COVID behaved like more of pneumonitis than pneumonia in the initial phases, with a lot of inflammation in the lung parenchyma that responded very well to steroids. But when you talk on influenza, it is more of pneumonia, and viral replication is shown to be more if you start giving steroids to such patients. And we never thought of giving steroids to influenza patients. So if you have a situation, that is what we are discussing today. Like it is very important to differentiate, especially at this point of time where there are mixed infections coming up. So again, the role of biofire assays, multiplex PCRs play a very important role. And also other part is like, as we know, the co-infections of other bacterial co-infections like staph and streptococcus infections are very common with influenza. Than COVID. Means like if you see COVID, we have seen bacterial infections in those patients who are very sick or those who are ventilated. But most of the times, influenza patients will have co-infections with staph and streptogram positive infections also are seen in these patients. So steroids may be sometimes more harmful to these patients. So it's not better not to administer these.
Yeah, so that was actually something very interesting. Hari, you had a you have a study where actually you looked into the co-infections with your filmfare array. So there was some questions. How many you have seen H1N1 with COVID-19 together?
So this we did only during the first wave of COVID, considering the cost factors of testing, because the company could not support more. We randomly tested around 100 patients, and we only got during the first wave of COVID maybe hardly 2 or 3 cases who are positive for H1N1 at that time who are COVID positive by PCR.
So right now, can we take this as a both COVID positive plus H1N1 positive in this current case? Sujata presented, where initially there were some clues of RT-PCR positive, later it was turned to be negative, more of an influenza positive.
That's what, like, we cannot totally deny a positive PCR test for COVID, but since he has got already vaccinated, maybe that might have protected him. And over and above, maybe he developed a new influenza infection. Not sure of it exactly.
In that context, how you actually play a role of steroids? Will you drop, or will you think it is more of a influenza rather than COVID?
Maybe in those samples, I think getting a better lower respiratory tract sample plays a very important role, because these nasopharyngeal swabs sometimes may be false positive or false negative. So I would personally feel like doing a sputum examination, not exactly a bronchoscopy in a very early stages of either it's an influenza or COVID. So a sputum examination can be more useful in differentiating these. Like if you subject um, sputum samples more than these nasopharyngeal samples, I think it will help us to differentiate. Again, cost becomes a very important factor. If you start doing influenza testing for all patients, it's a very high burden on the patient also.
There are some questions like, do you really add influenza cover patient coming to your ICU now?
Not to the ICU, but most of the patients who are presenting with these kind of symptoms who are already vaccinated, because for a simple COVID, you don't have to treat the patient like that. You just give paracetamol, which works both for influenza as well as COVID. So with these cases, what I am seeing now, I'm slowly started to give influenza tablets, anti-influenza tablets to these patients. I hope you agree on my point, like not in the ICU patients, but because by the time they reach ICU, they're already sick, and there is no point giving Tamiflu for those patients who are already past 5 or 6 days of infection.
Exactly. So you are trying to point out that the oseltamivir role is always in the early part of that viral replication phase, where 48 to 72 hours are the crucial phase. And once they cross that and come in a sicker state to the ICU, the role of oseltamivir has go to a toss. But many of us finally land up in giving it, but its role is always be dubious. There was another question that can dengue co-infection can happen with an influenza? Do you have any experience with the dengue co-infections?
I think Sujata forgot to mention about this patient. This patient had two more problems. This patient, when we did an ANA screen and myositis profile, his SNRMP was positive with MI2 alpha on the myositis panel. That was one confusing whether it's an autoimmune process which triggered with a viral infection. Second thing, when he continued to have fever spikes, we also tested for dengue, and NS1 came positive in the last week of treatment.
So that was a possibly there was an overlap of dengue being also positive when he had a higher grade spikes of fever of 103, 104.
but since his platelets and other parameters were not pointing towards a dengue infection, and also transmission wise, like he was in an ICU where we don't
See mosquito bites or incubation period. Okay.
so that's the reason why we did not consider it very seriously that it's a dengue infection. And also in COVID, we have seen some patients coming dengue positive, but we have not treated them.
And I still remember your interaction and in our intensive care when we had a multi-departmental team meeting with you and the rheumatology, when we have seen a autoimmune panel, including that ANA and profile being vaguely positive, we all thought about there is a positivity in this case, very such a subtle changes in the followed by positive. We stuck to that, and there was an ongoing high grade fever always confused us whether we are dealing with an overlap of autoimmune disease or another bacterial infection, where you rightly pointed out in during this 2009 even that time influenza pandemic, and followed by that last 10 years after that, influenza being always been co-associated with strep and staphylococcus co-infections more commonly than what we have seen with the COVID. In COVID, we have seen delayed fungal infections, late secondary bacterial infections related to the ICU GNBs when they got intubated, when they got tracked, and they got a secondary VAPs and pneumonias, but not many with a kind of a strep or staph aureus related infections in this situation.
So there was one more question here saying, can we add oseltamivir to all severe COVID cases? Again, that is the point already discussed. Like there is no point giving these antiviral medications in their late stages of infection, I guess. I hope Dr. Kola will agree with me on this.
So there are questions related to the antimicrobials in viral cases. Opinion on misuse of antimicrobials.
Opinion on misuse of antimicrobials. We have seen that more with COVID patients, like a lot of patients being treated with. Even if you see this patient, we have not started on any antibiotic initially, but we only started one because getting a sample, a proper respiratory sample, also becomes challenge in these patients. And if you remember this patient, he had in one of the sample, he's got an aspergillus positivity on the smear. So again, we gave a shot of voriconazole, and then he started to spike fever. Then there was a consideration whether this is a drug-induced fever because he has got a ulcer on his mouth and all these things. So it's quite challenging to make a decision based on these, like lot of like autoimmune positivity. If you remember, like a few cases previously, also we have one patient who was treated as COVID outside, and then his myositis panel showed MDA5 positivity, which is a very bad interstitial lung disease with a lot of progression. So antibiotics, maybe judicially you have to based on your for those patients, but especially for severe COVID cases, we have seen that those patients definitely harbor a lot of bacterial infections, and broad spectrum cover has to be given for those patients.
I still remember when this case came initially, the differentials were atypical pneumonia. The pattern looks like a viral or an atypical pneumonia. So I remember we discussing about the possibilities of a Legionella in this case or atypical cover to in this case, and I think we have evaluated on that part along with the viral pneumonia. So empirically, initially to cover a atypical coverage with strand, the common community acquired pneumonia, and then probably once you're sure about and dropping that is one. Second, I agree with you, Dr. Hari, the initial recovery and then followed by there is again another spike of fever, worsening hypoxemia, and a new infiltrates in the chest. We have seen that happening in more with influenza. So that is the time where I think, we need to evaluate, and the challenge will be to take a sample. The patient will be on HFNC or NRBM, and taking a lower respiratory tract sample through a bronch was not an easy task. And we tried to actually bring out some lower respiratory tract sample by looking at epithelial cells ratio to neutrophils. And from there, we tried to sample them. So there was another question. Patients with COVID and co-infection dengue is a challenging. D-dimer high because of COVID and low platelets due to dengue. Did you face any such cases, sir?
Even with COVID, we have seen many patients who have like thrombocytopenia. But usually dengue and COVID, like based on radiology, dengue, unless until it becomes sick and causes any pulmonary problems, usually it is very easy to differentiate both this. Maybe you don't rely only on testing these patients where tests come positive and you try to treat these patients, right?
Yeah, so I agree. See, what happened in most of the SAMs, leukopenia and thrombocytopenia can be overlap in both in dengue and COVID. So right now, the high grade fever, what we see with dengue, like 103, 104, with the severe body pains, rash, and now if we don't have any parenchymal involvement, and we see more of leukopenia followed by thrombocytopenia, and we just get a cross when we check for a COVID in this pandemic and it turns to be positive. It can be a dengue case with a positive COVID, which is asymptomatic or a mild. So that kind of overlap is quite possible, sir. Last even in Omicron variant in the third wave, we saw the similar kind of pattern where we have seen the patients coming with some other problem, either a CVA or a MI, or a patient came with an acute exacerbation of asthma. You test for a COVID, they turn positive. But then when you scan the lung, when you scan the X-ray, it was normal. So there is likely possibility that with the current BA5 surge, you test any patient who coming to your ER, they may likely to be positive. So your clinical maybe course, as you rightly pointed out, like is it fitting into the typical parenchymal COVID disease? Then you take it as a COVID. If it is not fitting into typical parenchymal COVID disease, you ignore the COVID positive report. You focus on the other alternative diagnosis which has been given.
But
Because
again,
anyway, for mild cases, you are not going to treat and do anything in COVID.
yes, when you talk on platelets, again, if you see in dengue, over a period of time, the platelet starts to improve. That is where we make. But in COVID, it is like after certain period of time, we see thrombocytopenia. So initially, they may be normal. So that is one thing which when you talk on platelets between COVID and dengue infections.
True. So what will be your take, Dr. Hari? With the limitation of time, I think we'll take your final comments. What will be your take? So this webinar we conducted to actually show our case series to the medical fraternity that there is a definite surge of influenza cases, and there is a definitely sicker group of patients which we are seeing right now in the influenza. So what will be your message to the audience?
Maybe I would conclude like this: like if a patient is coming to the OPD clinics with fever and who is already vaccinated with 2 or 3 doses of COVID, and his COVID PCR is positive, maybe treat him as COVID. No need to look at a COVID influenza overlap in those patients who are relatively normal coming to OPDs. But if a patient who is not vaccinated and his COVID PCRs or rapid test comes negative, I think it is important to test both the COVID as well as influenza in those patients. And patients coming to the ICU, I think it is important to test both for influenza and COVID, because again, treatment decision of steroids make a very large difference in outcomes in these patients.
So your message is clear that keep an eye on influenza surge. Now, because of this, both natural immunity by the vaccine and the vaccines which we actually got over the last 2 years or 1.5 years has given some kind of immunity, and Omicron, the way that spread and gave some immunity. So we are not seeing many parenchymal cases, but yes, we are seeing once this masks has been dropped, the lockdown has been dropped, the restriction has been dropped, we may see a surge in influenza cases, which can be catastrophic. And we have seen these 2 cases which needed a HFNC. One patient needed a proning, and the other guy needed a high NRBM mask, which are on the verge of crossing those normal supportive care in a smaller hospitals, needed a higher center referral. So please keep your eye open, and probably this is the message which we wanted to give in this webinar. And I thank Sujata in bringing those cases, and I thank Dr. Harikishan, who is not in the town, was traveling abroad, was in Jakarta for maybe it was a meeting there, but he was kind enough to be a part of it. And we thank Dr. Harikishan for his sharing of knowledge and his clinical experience. Thank you, sir, for your time.
Thank you, sir.
Thank you, all the participants. We conclude the session. Thank you all.